This chapter is devoted to special cases. This means special cases in the widest sense. These are cases which do not occur in daily practice, which sometimes also lead to headaches. We've already heard that Componeer is an efficient system. And efficiency is often the name of the game when we have to treat children. This case concerns an amelogenesis imperfecta generalisata, in other words, a complete disturbance of enamel formation on all teeth. In Switzerland, this is covered by the disabled person's insurance scheme. However, one has to wait until the person has fully grown. Problems sometimes occur before treatment can be given. Particularly with children, this often includes social problems. In this case, the parents wanted to relocate, but the child refused to attend a new school because of their front teeth. In reality, the situation looks even worse. The flash makes everything look brighter on the photo. The teeth are extremely mottled and are darkened. The situation is completely in flux and the permanent front already exists. The cuspids can be expected. They will be restored subsequently step by step. From the literature, we are aware that etching and bonding to dysplastic enamel is not 100%. But in this case, we did not have an alternative. Maybe adhesion will be a little less, but we have no choice. Time is often a crucial element with children. With this 10-year-old girl, it can be expected that she will become restless after 1 hour and that her level of cooperation will drop. Therefore, treatment needs to be fairly quick. Nonetheless, everything was placed under a dental dam. The teeth were prepared slightly on the surface. The enamel is quite porous and crumbly in places, which is why this part was removed. The teeth were etched and bonded, and componeers placed relatively quickly on the surface. This is precisely the situation where Componeer serves us well. We only have a limited time window to create the surface, with the direct technique, and shaping of the teeth must be performed relatively quickly. They are certainly too long and too large, but of course we can adjust that at the end. The problem in the posterior area will continue to exist, that is for sure. But the child will no longer be inhibited so much at school than before. The extension of incisors was discussed in the chapter Abrasion and Erosion. In this case, an abrasion is present. However, this is not caused by excessive parafunction, but is due to an anatomical arrangement. We see slight progenia and an end-to-end bite at the front. In other words, incisal edge meets incisal edge. This abraded the incisal edge bit by bit, resulting in relative elongation. Each fraction of the incisor that was abraded was followed by further pushing of the tooth. This meant that the tooth became shorter, while at the same time continuing to push up. This results in full contact during the end-to-end bite with an unvarying vertical dimension in the posterior region. If one restructured these teeth in the normal way, there would be no room. Bite elevation would be wrong in this case. Normally one would say, I need room, I need to perform bite elevation. But we had no vertical loss. The front is relatively steep. This is why one performs a palatal taper to create space as recommended in the first chapter, Preparation. To create space for composite and a counter abutment, and to be able to shift forward with the teeth. We created a taper and set with dentine. We shifted forward and slightly back and shorter with the anterior mandibular teeth to create a normal overbite. We can see the final bite situation before and after treatment. The patient can now bite normally. In such cases, it is advisable to recommend a protective splint. But one can also wait. A palatal counter-abutment had been prepared after all. However, should anything break, one would advise the use of a protective splint overnight. Here we have a new situation, the crossbite of lateral incisors. The normal incisors are at the front. However, the central and lateral incisors are behind the cuspids. The question arises, can they be shifted forward? The diagnosis gives us the information a cuspid is also involved in the crossbite. In other words, from the cuspid onwards, everything is part of the crossbite. One needs to come slightly outwards with the lateral incisors and also with the cuspid. Here the diagnosis is very helpful, as it also gives information relating to the aesthetics to be expected for the final outcome. One needs to be aware, in such situations there will be a marginal inclination outwards. The teeth pivot outwards, as otherwise we would not be able to get past the lower teeth. In this case, we have a similar situation. We can see the classic overbite, the sandy bite. In other words, tendency to class 3 or a real class 3. The mandible is positioned in front of the maxilla, and in fact we have a negative overbite. The anterior teeth of the mandible virtually protrude over the incisal edge of the upper anterior teeth. In part, this is extremely unpleasant for the patient, as the masculatory function is seriously impeded during eating. Movement of the temporomandibular joint is designed to move forward and backward, left and right. This it cannot do at present. The bite is blocked and only allows chewing where the maxilla strikes against the mandible. A grinding movement is virtually impossible. This would represent an obstacle for normal reconstructions. Actually, one would have to say that this is not possible. But with a reconstruction using composite, one can say it is possible. However, one has to make concessions. It cannot be done without preparation of the teeth. Here we can view the diagnosis. The amount of grinding is determined. Using a pencil, we mark where the lower anterior teeth pass over the upper ones. Using a permanent marker, we draw a line to designate by how much the teeth need to be shortened. As the tooth more or less has its complete length, one can assume that dentine will be found after 1.2 or 2 millimeters of enamel. There is therefore no risk for the pulp. In this region, one needs to build up a sort of curve. The incisors simply need to be brought forwards, and the incisal edge is transposed to buccal. One can see how much dentine mass is applied. That is a bulk of a good 2 millimeters. The incisal third will be built up by 2 millimeters and become longer at the same time. This allows transposing the incisal edge to buccal without becoming thicker. As a final result, the maxilla is actually positioned above the mandible. As the patient does not suffer from bruxism, a special protective splint is also not required. Quite the contrary. The patient feels considerably more comfortable as there is no longer any indifference of the jaws during biting. In other words, where orthodontic treatment is no longer possible, or where conventional systems fail, a new indication can be created or improve the situation by using composite and componeer. Here too, we have a tendency towards crossbite. The buccal areas are slightly reduced. As we want to shift forward slightly, we've moved the mandible back at the same time to correct the situation in this region. Things become more difficult, of course, when things are no longer right from a multifactorial point of view. Here we have erosions at the incisal edges, old restorations and extremely extensive restorations. Despite crossbite, the patient wishes for a more attractive appearance. At the same time, we can also see devitalized teeth. The lateral too is severely damaged up to cervical. It was decided to use a post for build-up and create a core. One can see how many of the teeth have been destroyed. There's virtually nothing left, and at the back we can also see a gap. This involves a number of factors. We have root-treated teeth, we have extensive restorations, and we have gaps requiring restoration. This can also be achieved with composite in combination with componeer, which provides the shape and color shade. This is a very interesting case. There are situations where too few teeth are divided across the oral cavity. This results in deviations. If one takes a close look, one can see the two very prominent cuspids. The reason they are so prominent is that we have a conical 2 on one side and no 2 on the other side at all. And we can see a twisted 4. We see the following dental status: 3, 2, 1, 1, nothing, 3, twisted 4, and the 2 is also in the crossbite. This is a problem we can solve. We know that we can shift forwards. The question is, how do we achieve symmetry in this region? Because the teeth cannot be corrected forwards or backwards. If we make the tooth wider, the 3 would be too wide, and the proportions would no longer be correct. If one looks at the final photo, then one can see 3, 2, 1, 1, 2, 3. Where there were 5 teeth, we now have 6. In principle, this can only be achieved with composite. What was done? We took recourse to this cuspid. This lateral incisor overlaps the cuspid slightly. Nonetheless, one can clean the teeth and use dental floss. But actually, a part of the cuspid is positioned in this lateral incisor. An optical trick was created. The base in the background was corrected slightly using a synthetic material and for placing the componeers. Componeers can be a slight challenge, but at the same time are able to achieve something which would normally be very difficult. These are unusual examples with their own history. This lady wanted to have her upper teeth made more attractive, as she no longer liked her old composite abutments. We made a diagnosis to see in which direction we could go. The lady said, "Sure, let's do it." But we have a problem. What sort of problem? She has a twin sister. And then things became clear. The twin sister was to have the same front teeth and, if possible, also be treated on the same day. So a diagnosis was also made for the twin sister. Here we can see the twins. They have different smiles, but they are twins. These are the two diagnostic situations. Here is the one sister and here the other. The two ladies were very particular with regard to their teeth. They had analysed their teeth pedantically and wanted to have a specific tooth shape. If possible, a small interincisal angle, a straight incisal edge, and so on. If one asked a dental technician to make identical teeth for two different patients, this would probably never work. One would always have to perform finishing, which one should not really do with ceramic. But with Componeer, I had the option of doing the same thing twice. And I can always correct the same thing twice too. That means I have the option afterwards of adapting patient 1 to patient 2 to more or less achieve homology in terms of shape. And so far, this has only been possible by using the direct technique.